Hi, welcome. My name is Evie Klein, and I am the chair of the board of the Design Trust for Public Space. And it's really wonderful to see you all here. I came to this wonderful community of the Design Trust through my background as an architect, planner, environmental psychologist, and scholar. And I know I'm not the only one in this room who has multiple identities, skills, and roles that brought them to this convening. We have students, urban planners, architects, public health professionals, city officials, artists, dancers, lawyers, social workers, neighborhood activists, and that's just the people who I knew what they did when I saw the list, who care about the future of New York City and the health and well-being of all New Yorkers. So welcome to the Restorative City convening. The Design Trust for Public Space is a nonprofit organization which I think you probably already know that unlocks the potential for New Yorkers, for New York's public space. And our unique project model is to take public space challenges and bring diverse minds together that otherwise wouldn't have been together on a team. And we put those ideas into action for a more just and equitable city. Sometimes these projects take a long time to come to fruition, and many of our partners and board members and people who know our work are very well aware of that. And so it's especially exciting today to have a one-day convening to share our ideas and stories, bringing a way broader group of people together than you could for one project, and really coming together to share our experiences and our thoughts and our aspirations and dreams and hopes on the topic of the restorative city. And it's both the ideas and things that come about today, during this day when we're together, as well as the many seeds that are going to be planted. And that said, we really couldn't have done this without the support of many people, including our sponsors. And we're very grateful to the National Endowment for the Arts, the Mellon Foundation, W Architecture and Landscape Architecture, Curtis Ginsburg Architects, HKS, Perkins and Will, and HOK. And of course, our generous venue host, the Ford Foundation, and the Restorative City Advisory Committee, who was really foundational in bringing a bunch of the dynamic speakers who are going to come and share their thoughts. Lee Altman from SCAPE, Uche Blackstone from Advancing Health Equity, Tamara Greenfield from Downtown Brooklyn Partnership, Josh Langham from the New York City Department of Health, Sloan Leo from FLOX Studios and a Design Trust board member, Suzanne Niedemer, an independent consultant, and Barbara Wilkes from W Architecture and Landscape Architecture, also a Design Trust board member. And on behalf of the Design Trust board, I wanted to thank you and welcome you, and also thank the Design Trust staff who really did a lot, an incredible amount of work and thought to bring this all together, which gives me the greatest pleasure to introduce and hand the podium to Karyn Williams, who's the program director of the Design Trust, who has worked so thoughtfully with so much dedication to bring this day together. I pass it to Karyn.
Thank you, Evie. Good morning. Again, I'm Karyn Williams, and I'm very excited about this day. We've excited that we're going to be having a number of great conversations that centered around health equity and the built environment. So today's conversations will be grouped, the sessions will be grouped into different sessions. The first one we'll start off this morning is seeing the built environment as a tool for health equity. And this conversation will set the context and explore some key concepts of the social determinants of health. Next session will focus on environmental change and justice. And then in the afternoon, we will also have a conversation centered around arts and culture as it relates to health equity. And then our afternoon sessions will be looking for a new vision. Will be a panel discussion with city officials talking about planning and designing for a new vision for health equity for New York City. And then finally, we'll talk about in the afternoon, the last session of the day, centers around civic participation and distributed decision-making as it relates to health equity in New York City. So we're excited to have you here. The format of the day is that all sessions will take place in this room. We will have breaks, in which time you can enjoy coffee or tea or a snack in the lounge, and then we'll join everyone back in here. Just go through a couple of house notes. For the Wi-Fi password, it is inside of your program. You can find it here. And we will also be using, for engagement, a platform called Slido. So after some of the talks, we'll have a Q&A. And Slido is, if you take out your phone, there's a QR code in this front portion of the program. And you just open it up. If you guys want to do that now, we can do a test. So, and let's give it a test and say, what is your favorite public space in New York? So, you take your phone, open the camera, use a QR code. Great. And then all our answers will populate there. And so again, if you have comments or questions throughout the day, you can use this. We also have a set of questions that are preloaded that we would love to get your input on. So feel free throughout the day to use that. And also on the back of the postcards too, you can also have the QR. You can find the QR code there. Great. So, oh wow,
Fun.
I know. Prospect Park is winning by far. All right, great. Thank you all so much. So we're going to get started with the program today, and our first speaker who will be introducing the first session is Sloan Leo. Thank you already.
Good morning. Thank you. Wonderful place to start today. My name is Sloan Leo, and I am excited to welcome you to the Built Environment and Health Equity opening session. I am a very proud member of the board of the Design Trust and also the founder of FLOX Studio, a community design and strategy studio that works here in Brooklyn and Manhattan. So the session we're about to have really explores the historical context that has led to the health inequities that so many of us are working to solve for. The only way we're going to be able to achieve more equitable health outcomes are by adopting new programs and frameworks and models like the social determinants of health. Over the course of this session, a strong connection will be demonstrated between health equity and the built environment, the spaces and the places that we call home, the places that we work, and the places that we live. This session will conclude with a presentation that includes going over some of the best practices and ways that inclusive design is the best design. Our speakers, Matthew Clarke, the Executive Director of the Design Trust for Public Space, will be in conversation with Dr. Michelle Morse, the Chief Medical Officer and Deputy Commissioner at the New York City Department of Health and Mental Hygiene. Following their conversation, Bryony Roberts, Lindsay Harkema, Irina, Verona, and Jennifer Carpenter will talk about their design practices and that advocates for public spaces in our city that offer inclusive zones where all of us, despite any sort of invisible disability, sensory sensitivities, or other kind of needs, are able to see these spaces as spaces for common ground. We're very happy to have you today. Please join me in welcoming Matthew Clarke and Dr. Michelle Morse to the stage.
Thank you. Thank you, Sloan. Thank you, Karyn. Thank you, Evie, for the really generous introduction. We're really excited to be here today. And thank you, Dr. Morse, for being with us. Ironically enough, on the last day of the pandemic, apparently, or it's over, which is, I'm curious to hear your thoughts about that. Well, maybe we'll get into that. I figured you would say that. I'm really, really grateful to have this conversation with you today. I first want to start with kind of a very general question about you and some of your work. What is a chief medical officer? And talk about your role within the city and what that means and how important it is for New York.
Thank you. Thank you, Matt. Thanks to everyone for being here. It's a real honor to get to be in conversation about the connection between environment and health. I think we don't talk about it enough. And so it's a real privilege to be representing public health in this space. Again, just a real honor to also serve as the inaugural Chief Medical Officer for New York City's Health Department. It's pretty fascinating to me that there hadn't been a Chief Medical Officer prior, but I think again, knowing today is the end of the federal public health emergency, linking that directly to the fact that COVID is part of the reason that this role was created. As you all know, New York City was the epicenter and one of the first places where the impacts of COVID were felt very dramatically in the global stage. And part of the reason that this role was created because the way that our health system, if you want to call it that, is set up is it's incredibly fragmented, right? We have primary care over here, we have hospitals over here, we have community-based organizations over here, we have all kinds of different health workers, and then we have public health departments like the New York City Public Health Department, but structurally they're not really connected in terms of data, in terms of treatment protocols, in terms of policy guidance even in many ways. And so the challenge in COVID in particular was bridging all of these different parts of our healthcare and health ecosystem and trying to do so in the middle of an emergency. It was a huge challenge. So part of what I was brought in to help to do was to continue to build on what the health department was already doing in connecting with healthcare organizations specifically, and really bring more connectivity, more platforms for convening, for sharing the challenges, brainstorming solutions, and really helping and partnering with all of our healthcare delivery organizations, whether that's federally qualified health centers, primary care centers, the big academic medical center systems, our safety net hospitals, helping them to have the information they needed to make plans, policies, and act in the middle of the emergency. And then also for the long term, build more connections between how they're thinking of diabetes, for example, or hypertension, and helping them to kind of get on board with what I would say is our public health prevention agenda. So how do we help them, or how does our team in the Chief Medical Officer team help them to move beyond sick care and really move upstream to get more into the prevention side? The COVID vaccination campaign is one of the best examples, right? In the first year and a half of that campaign, 8 million vaccines across the whole entire city were given. And there's no way the health department could have done that alone. We actually had to do that in partnership with healthcare organizations. And so one brief initiative I'll also describe that's not a COVID one to help again emphasize the fact that this connection between healthcare and public health has to transcend emergencies. We also, one of the things that we launched is a coalition to end racism in clinical algorithms. And some of you may have heard a little bit in the news that unfortunately some of the way algorithms are used in clinical medicine and in public health is it uses race and ethnicity in a way that actually solidifies racial inequities in health outcomes instead of upending them. It normalizes them and accepts them instead of saying, actually, race and racism are absolutely, racism is preventable, right? We can actually change the way racism impacts health outcomes. So this coalition has 11 of the largest health systems across the city that are a part of it, all working in concert, to say, instead of each of us trying to figure out how we end the way that race and racism have been impacting clinical care, we can actually have a shared series of implementation guidelines so that not every system is doing it differently, and so that it can happen more quickly and be an accelerator so that we don't have to wait 10 or 20 years for practice to change.
I want to circle back to both race and racism. That's a critical topic. There's also something fundamental to today, which I want to maybe unpack with you and help we can all kind of understand together, which is this idea, and you mentioned a little bit with these upstream determinants. There's a concept that something that I've, as a planner and architect over the past 5-10 years, have really transformed how I think about the world around us, how we shape it, who is shaping it, is that actually architects and designers are health workers in many ways. And it's actually a powerful perspective to have, and it really, you have to face yourself in a way
Right.
and your work.
Right.
But could you talk a little bit about what the social determinants of health, what they are, what it is as a concept, why people in this room, if they have a background maybe in planning and design, why should they care about that, and how can they maybe contribute to that conversation?
It's a phenomenal question, and at the health department, we think everyone's a public health worker, so I'm glad that you're on board with that identity, Matt. And we certainly agree. I mean, part of the reason that we can even be talking about the social determinants of health today is because so many decades of both healthcare, public health, and cross-sectoral folks have said, look, there is a way that all of our work is connected. And sometimes it's the health outcomes that are really just the indicator, but the conditions that create those health outcomes are everyone's responsibility, including architects. So I'm really, again, glad to be in conversation with you all. So what are the social determinants of health? Well, I think many of you are familiar with kind of the medical causes of health outcomes, diabetes, as I mentioned, other chronic diseases. But then there are a number of conditions that, the conditions in which we are born and live and age. These are the conditions that really shape the possibility of health or the lack of that possibility. And so the social determinants of health are really just an organizing framework for us to think about, well, how does the fact that I am unhoused and living on the streets, how does that impact my ability to control my diabetes, for example? Or how does the fact that I live in a neighborhood that doesn't have a single park within a 20-mile, a radius, or whatever it might be, how do those conditions actually impact my ability as an individual, but then also my community's ability to actually achieve these health outcomes that we're all looking for at a societal level? So housing is one of the biggest ones. The racial wealth gap, or wealth and economic income, those are also huge determinants, social determinants of health outcomes. We often also talk about education as a social determinant, and there are many others. So these are the conditions that create the possibility of health or the lack of that possibility. And all of us have a responsibility in understanding, well, what are our policy decisions? How does the health of our democracy, how does our ability to actually drive the political will to change social conditions then result in improving health outcomes or not? And so, again, COVID is kind of the most dramatic example of many of these things. But what you all saw, of course, in New York City was there was a very clear pattern of who was impacted the most by COVID. And you can look at neighborhood, you can look at the job or, essential workers, you can look at race, ethnicity, you can look at so many different variables. And unfortunately, those patterns are predictable, but they're socially created, which means that we can change them. And so that's how the social determinants framework helps us to think about, well, what are the decisions and policies that we need to make to actually create health, the conditions for health for all people.
I think it was last week or maybe a couple weeks ago, the Surgeon General talked about loneliness as an epidemic in this country. And obviously loneliness is a social construction, but cities are places that can be very lonely and be very social. How do you all think about both loneliness and mental health, and how does that intersect with the kind of city we're hoping to create?
Yeah, it's a phenomenal question. And I think the Surgeon General's report, it's one of the first times I think folks are really recognizing, like, oh, wow, there's actually a health impact, right? There's an impact on chronic disease. There's an impact on stroke, heart attack, all of these other things that you would think are just, again, very quote unquote like medical or biomedical. And in fact, there's a massive social impact on all of those kinds of outcomes. So part of the way that we think about it certainly is, how do we, again, invest and create the conditions and work with folks across sectors like you all in architecture and engineering and many other disciplines to say, if we're designing for health, if health is the outcome, what are the conditions that we can create? And again, how does investment help to do that, right? One of the things that we've also seen, and this is a very interesting kind of research area right now, is if you look at wealth, wealth is another predictor of experiences of, happiness, health protection. Self-rated health is higher for people who are higher wealth. And so there's a number of ways that these kinds of social drivers actually shape who might feel lonely, who might, develop, either anxiety, depression, or other mental illnesses. Those, again, are things that are socially constructed and that we can design to improve.
Mm-hmm. I want to talk a little bit, and we'll hear actually in the next session some of the work that's been happening with Plan YC and looking at climate change, which is wonderful. And one of the things that's clearly true about that work is framing climate change as a health issue.
Right.
I think one of the things that maybe is frustrating, maybe is exciting, is that when you start to pull those determinants, that upstream work, there are so many other, call them departments of the city that need to be at the table. How do you work kind of in that matrix? What could be done to extend those connections even stronger? Is there some work to do?
I mean, that is one of the biggest challenges. I will say I spent most of the past 15 years in kind of the academic and nonprofit world, and spent a little bit of time on the Hill, and then have been here this is my first time really working in government, in an agency. And I will tell you that has been one of the biggest areas of learning and growth for me, is how do you work across agencies and across sectors in government when just getting the day-to-day work done if in your own agency, yeah, that resonates, is so challenging, right? And you need to have space for collaboration, space to go across town to the other agency's office, for example, for meetings, space to build those relationships, space to also even understand the current landscape of what other agencies might even be doing that's relevant to the question of either health equity, design, et cetera. So I will say it's not a nut that I've totally cracked or a problem that I've totally solved, but I do think part of it is actually being able to start with relationship building, and also the more we in the health department can help all agencies see their potential role and impact in health outcomes, and sharing the data with them so that they can actually use that data, the health data in particular, to say, oh, wow, our work in, the EMT system in the fire department, for example, or in DUICD, or all of these other areas actually will impact these health outcomes. Mm-hmm. That in and of itself is an important starting place. We're already far along, I would say, in that conversation. The social determinants help us to make it even more concrete. And now the challenge really is, how do we create space in our day-to-day for that kind of cross-agency collaboration? So
I think it's something that we see, Design Trust as an organization, historically and to this day, we work with agencies across the city. It's one of the things that I think we're most proud of. And agencies have increasingly been thinking in terms of their kind of human outcome. Like, what does it mean? And there's shout out, I think the PDC is in the room, the Streetscapes for Wellness plan, which was just released. They're thinking about, how does streets make us well? How does, you mentioned housing make us well? How does clean air make us well? And that needs to be a bigger table. And I think that's something that we're excited to be part of that. And I think the nonprofit community, the advocacy community can continue to build that room. And I think it's something that fundamentally important for New York and our future. I want to circle back to something you mentioned earlier in your kind of first remarks about racism. And for a lot of people, I think that's, well, how is that a health issue? But it's something, particularly in the public health world, that has been pervasive as an issue, but as something to address. And a lot of cities and other municipalities have, signed on to declarations about racism is a top-line health issue. Why is it that central thing to think about and not something to the side? Why is it that's such a core part of how we think about all of your work?
It's such an important question, and I just want to start by saying I'm so thankful that in a conversation like this we can name racism. 10 years ago, 15 years ago, there are many spaces in which that's taboo. And Dr. Kamar Jones is someone who's been a mentor to me. She does a lot of work in the realm of the connection between racism and how it shapes health outcomes. And she always talks about the fact that the first step is naming racism. So I'm glad that we can do that in this space, and I would guess that it's going to be a part of lots of the conversations today. The health department here in New York City passed a resolution declaring racism a public health crisis in October of 2021. And it was in large part, of course, informed by many years of work in this city looking at place-based inequities, right? So if you live in this block as opposed to if you live in this block, we can predict what your life expectancy is, what your health outcomes are. That, again, is completely socially created, right? Completely socially designed, which means we can change it. And so the fact that the health departments across the country, so after the murder of George Floyd, there was an exponential increase in these declarations being passed. There are now over 250 locales across the country that have passed resolutions declaring racism a public health crisis. And I think one of the most kind of tangible expressions of that is something I suspect many folks are going to be talking about today, redlining, right? We talk about redlining as one of these really concrete examples of how racism shapes health outcomes. So, this is a federal bank policy created in the 1930s that decided to say, well, this neighborhood is too risky to give a mortgage or a loan, right? And guess which neighborhoods were too risky, right? It was the Black neighborhoods, it was the Latinx neighborhoods, it was the poor neighborhoods. And if you look at the map of redlining in New York City, and then you look at the map of the worst health outcomes to this day in New York City, it's the same neighborhoods, right? It's the same neighborhoods. And so part of our response to that in the New York City Health Department is work that Dr. Mary Bassett did as commissioner, is developing neighborhood health action centers as an approach to reinvest, right? Reinvest in the neighborhoods that experienced redlining, because we know that those are the investments that are going to transform the health outcomes, right? And so having spaces like the action centers, we have one in Brownsville, we have one in East Harlem, not that far from here, we have one in Tremont in the Bronx. These are the neighborhoods where our whole entire city, engineers, architects, health department folks, all sectors need to be orienting their investments, programs, and work. And that's what we mean when we say centering the most impacted, centering the most marginalized. That centering can actually translate directly into a place-based prioritization. And, again, we did that in COVID, in fact. When we did the Public Health Corps program, a community health worker program that launched across the whole entire city, we didn't put a community health worker or a community-based organization everywhere. We put those investments and resources and programs in the neighborhoods that experienced an unfair impact from COVID. So that all translates into the ways in which racism, systems and levels of racism shape the health outcomes. And redlining is something that we to this day have to counteract, right? Because we see in our health outcomes that it's actually still impacting who gets sick and who doesn't.
Mm-hmm. And we're seeing that housing discrimination still exists.
Absolutely.
People think of redlining as
going away.
a historical thing
That's
that
right.
we're reckoning with and trying to repair, but it's housing discrimination, racism is present today in neighborhoods across the city, across the country.
Absolutely.
And I think it's important to identify that and reckon with that. You mentioned something really important that I don't want to kind of gloss over, which is the sense of neighborhood action centers, which is actually a pretty profound, maybe if I say shift, I hope that's accurate, in thinking about place-based approaches to health. And I'm so attracted to that, or appealing, because that starts to talk about community building
That's right.
and design, but these are actual centers. So talk about how that approach emerged, why it's important to think that way, and what have you been learning from that work in those three centers?
It is such a great example of how space can shape policies, outcomes, organizing. The spaces that the action centers represent and are spaces for collaboration. They're kind of the spaces that allow us to convene, to get together, to work across sectors. So the vision behind the action centers was, as I described a little bit, a reinvestment in the neighborhoods where we know we have to improve health outcomes, knowing the patterns across the city. So that's why they're located where they are. But then the spaces themselves, and anyone who wants to come visit an action center, all you have to do is come find me. We can set up a time. Because even walking through the action centers, I know my blood pressure goes down, I start smiling, they're really beautiful, they're clean, they're the kind of space you want to come into, right? And they have a number of different services and organizations. So part of the goal was to actually make government more accessible to communities and community-based organizations. So we have health department staff in these action centers, and some of the health department folks might be here today who work in the action centers. The staff are there, and they might be doing programs like our family wellness suites. They might be doing pregnancy prevention, teen pregnancy prevention programs. They might be doing pest control programs. So we have health department staff present. Then we also have community-based organizations, and we have federally qualified health centers. So, and we also have dentistry in some of these action centers as well. So the idea is it's a structural place and space where that collaboration between government and community-based organizations and healthcare organizations can actually happen. Now, the other beautiful thing about the action centers is there's also just community space. This is a beautiful community space. I think we all experienced the same, calm when we walked into the rainforest that's happening out there. But the space in the action centers, there's community rooms that community organizations and community members can rent out for free, to have their meetings, to actually meet with us, to meet with other people who are or entities in the buildings. So it's kind of a way of designing a space for collaboration across sectors and a space that feels safe, therapeutic, and accessible to the communities that, again, we know we have to reinvest in.
I think it's so great you talked about that feeling of being in that space and feeling well. And it's hard to kind of, obviously this is a wonderful space to have this conversation, but that, the garden in particular, it's everyone deserves to feel like that when they're moving through their city.
That's right.
And I think making those investments, particularly in communities that have been marginalized, underinvested in, it's just really critical. So I'm curious for someone, not trained as a designer, how do you think about that? I know the health department has thought about the arts, has thought about design. That's something that's, we, a design trust, and many of you in this room think about and care about. So why does that design matter, and how can we lift that up even more, I think, in this work? Absolutely.
Well, it's such a phenomenal question, and I suspect there'll be lots of conversations about this throughout the day today as well. But it is pretty amazing to see how much environment and space just can shape your self-rated health. It's one of the outcomes we look at the health department, because it actually is correlated with your actual health. The way you rate your health correlates pretty strongly with that, which is fascinating. But one of the things the health department has done, and that I've began to learn about when I first joined 2 years ago and some change, is the active design guidelines that we've done in partnership with many of you out there. And that was such a wonderful and beautiful concept to me, right? Because it's true, right? If you're not a doctor, how would you really think about, like, okay, well, how do I take care of this, right? And so the idea is really, this is kind of a set of guidelines and a framework that folks who may not be health or public health people per se, like by the strict definition, can really consider health and consider health outcomes and safety as a part of the design. And I think it's a really beautiful tool that represents that translation across sectors, right? And because it was created in a way that is interdisciplinary and cross-sectoral, it's also a way to begin a conversation, right? It's a way to kind of open up a conversation about how can all of us see our role, responsibility, and accountability and stake in designing in a way that produces health, creates safety. So I do think that those guidelines, and I believe Kim Kessler, who's an assistant commissioner over the Chronic Disease Bureau in the health department, is going to be talking more about the next version of those guidelines this afternoon as well. But again, we need the really tangible, concrete things like those guidelines. Otherwise, we end up with a bunch of people talking about it, right? And these are the things that allow us to actually move that work forward.
So I want to ask a couple-part question, kind of go into the active design guidelines, which we're really excited to see that second iteration, because the first was so powerful, and I think the second has been a wonderful process, really looking at people and engagement and civics in a beautiful way. What's kind of your dream, kind of big plan for the city? Thinking about, I know you all have been busy there's been a pandemic, but there has been a pandemic. We are still
Right.
But the pandemic has only, just reinforced inequities in our places and cities and neighborhoods. What's a big idea you have about how to bring this health to this idea of health to more places? A big vision? I'm not sure. I'm kind of asking off the cuff. Do you have some kind of big idea about that?
Oh my God, there's so many things to think about. So I'm new to New York City. And I will say, yes, what a welcome, right? COVID was quite a welcome. So it's why I came, obviously. But there's so many things that we learned during COVID about the ways in which this city and many other cities are really not set up for safety. And so I think there's a lot to think about, and there's been a lot of work already just on things like, bike lanes, like creating safety around walking, being out in the environment. I think all of those things are magnificent. But I'm very interested in this question or this conversation that's happening about wealth. And wealth, I should mention, is, you guys are probably aware, right? It's different than income, right? Wealth is assets minus debt, right? That's a very different indicator than income, right? You may have a lot of debt, but your income is $200,000 a year, right? There's all different kinds of debt that might happen, but the more common scenario is really really low amounts of wealth. And the wealth pattern is not dissimilar to that redlining pattern that I was just talking about. So I think one of the things that we really need to be better at in the health department is looking at wealth and not just income and how it tracks with health outcomes. And the reason I'm mentioning that as a big idea is because reinvestment is so central to health inequities, bless you, and yet we can't seem to muster the political will, the policy changes, et cetera, that would allow us to leverage the vast wealth that exists in this city towards the neighborhoods that have experienced structural racism, redlining, disinvestment, et cetera. And so I would love to see us really dreaming big about what reinvestment could look like, what addressing the racial wealth gap could look like. It's something that I saw a lot in Boston before I came here. In Boston, the Federal Reserve Bank did a study and showed that the average white family had $247,000 in wealth. The average black family had $8, right? And so, I saw the wows in the audience. You know, the Boston Globe got phone calls saying there's an error, you printed an error, because people couldn't even believe that that was the case. And then, of course, on the health department side, we're talking about, well, then how does that shape your health outcomes, right? Because wealth is protective. So, you know, big dreams, of course, would be using that framework around wealth to guide reinvestment, and then looking at what the health outcomes look like if we're able to make that possible. Now that's pretty big, and it's not just individuals and families, it's communities. Yeah. The institutions in redline communities are also less wealthy, right? Mm-hmm. So it's the individuals, the families, and the institutions. Right. The safety net hospitals in New York City, which are in large part in redlined communities, they have less wealth and less resources, as do the communities that they serve and the families that they serve. So looking at that, I think, is going to be really, really critical to take us into the next era of health equity work.
It's fascinating to hear you talk about, I'll say economic development, but that's the wrong term, but
Justice.
Talking about wealth and,
Yeah.
and money
Right.
and resources. I was going to actually, last week, I think the Irish, this is a weird reference, but the Irish president made a really powerful speech that nation states shouldn't be focused on economic development and wealth creation. That is an outdated concept in this era, and we need to be thinking about human dignity and well-being. And I thought, wow, that's so powerful. So I'm wondering how you would I'm just kind of throwing out an Irish president reference, which isn't a common thing. But how do you react, which I agree with, but how do you think about that in terms of, because I think what you're saying is reinforcing that, which is wealth shouldn't be the kind of sole goal of a few people to have.
Yes.
New York is a redistributive city.
Right.
It is a fact.
Could be.
It could be more.
Yes.
Thank you for clarifying. How would you react to that, and how would you kind of add that concept into your kind of statement there?
I will say there is not a day that goes by in my current job where I'm not thinking about what is the role of government? What is the right role of government in this work or in this particular area or in this particular moment? And I have a lot of thoughts about it, I will say. I do think it's true government can't do everything, and yet I still see government as the safety net, right? As the entity that ensures that everyone at least has the bare minimum that they need to thrive and survive. And, at its best, can be one of the many institutions or a series of institutions that ensure justice and protection for the most marginalized. I'm someone who believes very deeply in this concept of social medicine, and it's to take it back to the 1840s, there's a physician named Rudolf Virchow who spoke about not just a bunch of medical things, but also said that doctors are the best advocates for the poor, and that medicine at its best is around social equity and social justice. And so I guess I would say, government can't do everything. And yet, if government is not protecting the most marginalized, I'm not sure who will. So I would push back a little and say that, the tax policies are one of the most important ways to express those values around justice. And if government is not using tax policy to ensure well-being and health, I mean, what is it doing, right? And so I know tax policy sounds wonky or maybe, technocratic, but in fact, if we were able to reform our tax code to make it more progressive, a lot of the issues we're talking about right now really wouldn't be an issue.
It's incredibly bold and inspiring to hear you talking about tax policy and wealth, and hearing that in the context of health is inspiring, and I'm really grateful that you are our Chief Medical Officer of New York City. We're really lucky to have you. I want to ask you one last very quick question. Is you didn't get a chance to answer the Slido, which is your favorite public space in New York?
Oh my gosh. Okay, well, since I have the opportunity, I live in Bed-Stuy, and this morning even, I was working out in Von King Park, which is one of the parks in Bed-Stuy. It's like a 10-minute walk from my house. I absolutely love it. It's like a perfect mix of like regular, beautiful walking space park and kind of like the club, honestly, and like everything in between. It's a really special space.
Well, cheers to public space. And
Yes.
Thank you so much, Dr. Morse, for being with us today. Thank you so much. Thank you all. We're excited to be here, more to come, but now we're going to welcome our first design story of the day.
Great.
Thank you.
Thanks.
Welcome, everyone. Neurodiversity is a term that's about 25 years old, but awareness of this term has exploded over the last few years. There's no universal agreement about what it means.
You'll hear someone say an individual is neurodiverse.
Or that society is neurodiverse,
Some use neurodiversity to describe just the autism spectrum.
while others include a wider range of neurological identities.
Some feel this concept perpetuates an unfair hierarchy of disabilities, with neurodivergence at the top, excluding some that others consider so-called high functioning.
So language is not easy, and we want to be clear about what we mean today with the use of this word. We cast a really wide net with the term neurodiversity.
We live in a neurodiverse world where differences in brain functioning are a normal part of the human population, where almost 1 in 5 New York City students is diagnosed with a non-physical disability, including autism, dyslexia, dyspraxia, Tourette's, and intellectual and neurocognitive disabilities. These identities go across race, age, gender, and economic background. We live in a city where many must navigate the complexities of the urban world while also dealing with anxiety, mental illness, and post-pandemic trauma. The experience of the city is communal, but it is also individual, mediated through our bodies and our senses, and thus it's different for everyone. And for many neurodivergent New Yorkers, the city creates barriers to participation. And if you can't equitably engage in the spaces of the city, how can you be an equal citizen?
This is a question that I ask about my son, Booker. He is autistic, and he's now a young adult trying to make his way in a world that is not designed for him, because he falls outside the bracket of the so-called typical. My son's world is New York City. He loves New York City. And through his eyes, I have found new sources of joy in this place. Booker is the MTA's biggest fan. In his spare time, he maps out how he would improve the subway system. And he has great ideas. Some of them are on his whiteboard. The MTA should listen to him. He is most at home in the subway system. But even here, the spaces are sometimes hostile to him. The communal space of the platform, where he spends a lot of his time as a rail fan, is a space of overwhelming sensory input that he struggles to process. So there are bright lights overhead, often flickering. there are overwhelming smells. There's a barrage of sounds. He has great anticipation about the train that's about to arrive. And if he can sit down, he can contain that energy, but there's often inadequate seating. And so to discharge that nervous energy, he needs to vigorously pace and to skywrite. And these were behaviors that when he was a train-obsessed autistic child were tolerated, but now he's a 6'2" autistic man who sometimes makes people uncomfortable. So uncomfortable that he has been escorted from the platform by police officers more than once. And so every day, including today, I worry about what will happen when Booker annoys or scares the wrong person. And then I wonder, how much more would I worry if he were not white? We live in a neurodiverse city, but we are intolerant of difference. Who is the world designed for? It's not designed for those that are in between those pretty tight brackets of our societal norms, but it should be, and it can be. So how do we redesign the world? Where do we start? I started with the help of my partner, Irina, who helped me realize that what I had learned from and with Booker and the neurodiverse communities that we've been a part of for the last 2 decades was in fact the foundation for a design approach.
I started with Jennifer, learning a different way to think about who we design with and for. I had long known that it is our duty as architects to design to dismantle barriers for people with physical disabilities. And we have codes and laws in place so that whether you can walk through a door or climb upstairs does not determine if you can go to the library or play in the park. But what about the barriers faced by those with less visible, non-physical disabilities in our neurodiverse city? Barriers like spaces that offer no escape from sensory input, like the train platform Jennifer described. Barriers like spaces that offer enough sensory input, such as a lunchroom at our neighborhood elementary school, where a child routinely throws himself against the column because he has no way to get the tactile input he needs. Barriers like rigid planning about what activities take place where in public space. Barriers like limited ideas about what constitutes valuable participation. Look me in the eye, raise your hand, don't pause too long. And perhaps the most significant barrier, limited ideas about what it means to have worth and to be worth making space for. Our practice is dedicated to dismantling these barriers, and we are doing it in collaboration with the neurodiverse community and self-advocates, including our partners for the Design Trust Project. We are making spaces with more affordances, meaning more offerings for more people, more options for ways of occupying, including a range of sensory environments. We believe that sometimes redundancy is necessary, providing multiple spaces with multiple sensory characteristics that give choice and agency, instead of a one-size-fits-all space that doesn't actually fit all. And we're embedding these design strategies throughout our projects so they can't be simply cut from the budget. The great news is that when you design to meet the urgent needs of some, you're actually making spaces that are better for everyone.
So let's get back onto the subway platform for a moment and imagine how might we make it more neuro-inclusive. What if more of the lighting were indirect? What if every subway station had a restroom? Did you know that only 16% of subway stations have restrooms? And what if they were well maintained? Wouldn't that help with the smell problem? What if ceilings had acoustic baffles that could better control sound? And what if the MTA workers who used to hand out masks could hand out earplugs when they're needed? What if some of those workers were occupational therapists? What if there were tactile surfaces meant for interaction? These moves would make the subway platform so much better for Booker, and I bet they would make them better for you as well. We know that redesigning the world for more inclusion is not just a design problem, and we know that a well-designed space cannot make up for an intolerant culture, for a lack of access to needed resources. But while design is not sufficient, it is necessary. And the insufficiency of what we can do frustrates us, but the necessity of what we are doing drives us forward. Thank you.
Hi. I'm Lindsay Harkema, and this is Bryony Roberts. We're representing WIP Collaborative, and we're thrilled to be collaborating with Verona Carpenter on the Neurodiversity project with the Design Trust. WIP, Work in Progress, Women in Practice, is a collaborative practice shared between independent women design professionals who work together on projects that engage communities and the public realm. Our team combines expertise in architecture, urban design, interior design, fashion, landscape and sustainable environments, and community engagement. And our research and design projects foreground considerations for embodiment, neurodiversity, and collectivity. Amidst the social isolation and mental health crisis of the pandemic, we started researching how public spaces could be designed to be more supportive of neurodiversity through virtual interviews with a range of voices, including individuals identifying as neurodivergent, families of children with autism, occupational therapists, and related experts to better understand their personal experiences and environmental sensitivities and preferences. The interviewees were asked to respond to a visual collage and discuss their preferences, what kinds of materials and atmospheres they were drawn to. The theme we kept on hearing about was choice, the need for choice in the built environment. Different people have different sensory sensitivities, and neurodivergent individuals often have heightened sensitivities that can make public spaces uncomfortable, inaccessible, and unsupportive of their needs. After conducting these interviews, we had the opportunity to explore how a public space could be designed with these considerations in mind through a public streetscape installation that we created in the summer of 2021 in Lower Manhattan in partnership with the Urban Design Forum, Hudson Square Properties, and the Hudson Square Bid. It's nice to see some friends from the Urban Design Forum here today. The installation, entitled Restorative Ground, occupied the spatial footprint of the outdoor dining structures implemented during the pandemic and offered a public landscape of choice and a vision of immersive and inclusive public space. The installation transformed an underutilized block in Hudson Square into an inviting and immersive shared environment intended to welcome members of the community back into the public realm after the social isolation and collective trauma of the pandemic. The installation was designed to facilitate different experiential zones that could support a range of spatial preferences. Architectural elements and material applications within the zones created interactive structures and tactile surfaces for individual and collective engagement, social gathering, quiet individual retreat, and active play. Now Bryony will share, After the installation was built, we also had the opportunity to conduct observation and research about how it was used, and again found an amazing range of activities, age groups, and different kinds of social engagement could happen in one space, collectively, in close proximity to each other. reinforcing the idea that environmental choice creates a more inclusive public space. And now I'll hand it over to Bryony to explain our work with the neurodiverse city.
Thank you, Lindsay. So just to touch on this project we're doing with the Design Trust, we have the opportunity to work with Verona Carpenter and the Design Trust on a project that would ask the question, how can the whole city support neurodiversity? How can all of the public spaces of New York support the full range of cognitive and sensory experiences? And offer not just the bare minimum of accessibility, but actually enable joy, connection, and empowerment. And this is something that's been explored somewhat in the design of interior spaces, in schools, in museums, but really not in the public realm, and there are not design guidelines for this work. So to do this project, we're partnering with many community organizations that support and empower people with disabilities, such as Include NYC, the Center for the Disabled New York, and Harlem Independent Living Center. And together, we'll be creating a process of participatory research and design. We'll be guided also by an advisory council of self-advocates, psychologists, occupational therapists, and advocates. And the goal is to have a truly collaborative process from start to finish that elevates the lived experiences of people with invisible disabilities and mental wellness challenges. So this is going to be a 2-year process that we're just starting. We're mentioning this partly also to encourage collaborations with many of the people in the room. We are designing a process that moves from analyzing the problems in existing spaces to developing design guidelines and policy recommendations. Part of the challenge in actually coming up with proposals is a lack of data, a lack of understanding the problems with existing types of public spaces. So the first phase is a sensory audit conducted with self-advocates on site, where we start to record sensory experiences and identify challenges. Then we move through prototyping in co-creative processes of workshops, imagining transformations to existing spaces in collaboration with local partners. And then analyzing and workshopping constructed prototypes to figure out what works and what doesn't, which will inform a process of recommendations. So really facilitating conversations between self-advocates, between city agencies, to imagine how policy can change the way future public spaces are designed. The goal of this project is really systemic change, so that from the ground up, we can imagine much more inclusive design guidelines for the future. So we're just starting this 2-year process, and hopefully we'll have a chance to intersect with many of you along the way. And the goal of all this work, as Irina and Jennifer mentioned, is really to imagine this very large-scale curb cut effect. So as many of you know, the curb cuts that exist in sidewalks originally were there to support people using wheelchairs, but support so many other people as well. People, the elderly, people pushing strollers, delivery workers. So if we imagine the kinds of transformations in the public realm that can support a range of sensory experiences, it would benefit everyone in New York City. So we look forward to being in conversation with you throughout the day and to sharing our work in the future on the neurodiverse city.